So, the lead research article of the April 2020 edition of the Green Journal is excellent. It's called Prospective Implementation and Evaluation of a Decision Tree Algorithm for Erotive Hysterectomy. It was done at the Mayo Clinic in Rochester. It's actually research that was done and presented about 3 years ago, but just now being published. It's more evidence and confirmation that vaginal hysterectomy is the preferred route of hysterectomy. It's associated with lower cost, better outcomes, better patient satisfaction, etc. They use an algorithm different than the one that I suggested in my book. It's less aggressive for sure. But with their algorithm, they found that 99% of women who were intended to have a vaginal hysterectomy were able to have one. They also found some women who they thought would have a robotic hysterectomy didn't need one, and they were able to have a vaginal hysterectomy instead. They use an exam under anesthesia to determine this, which is something that I don't think is incredibly useful. Still, more than half the patients that underwent hysterectomy during the time span of the study were able to have a vaginal hysterectomy. And they concluded that vaginal surgery is feasible, carries low cost and excellent outcomes, and that it definitely has a role in gynecologic surgery despite some limitations and some problems that face vaginal hysterectomy. This study supports what we already knew. This is evidence that existed for a long time. Bob Kovac published a similar study in 1995 and used his algorithm to find that 88% of all patients were able to have a straight bad chest performed by residents, and almost all the rest had laparoscopic assisted vaginal hysterectomies. In this current study, only a little more than half of patients had a vaginal hysterectomy, and that's because their algorithm is more restrictive. Now again, I presented an algorithm in my book that I think is the most evidence-based approach. It's what I and my partners use in our practice. We take all sorts of gynecologic patients, and we have a better than 99% rate of vaginal hysterectomy over the last several years, and I'm more than 97-98% successful for my career when we count the rare laparoscopic assisted vaginal hysterectomy. Accompanying this excellent article, though, is an editorial by Arnold Advincula. He's a nice guy who's interested in robotics more than anything else. In fact, he perhaps has several conflicts of interest in that regard. He has a patent and receives royalties for some endoscopic hysterectomy equipment. He's compensated by the folks who make the robot and has worked extensively with them over the years. But he was invited to write an editorial about this new study. I do think it's interesting that he was invited to do so, and I could speculate about that, but I won't. There are many other candidates who could have been invited to write this editorial, and I don't mean me, but people like Carl Zimmerman or Thomas Julian, for example. Thomas Julian, in fact, wrote an excellent editorial in the Green Journal in 2008 that's definitely worth reading. It was called Vaginal Hysterectomy, an Apparent Exception to Evidence-Based Decision-Making. He discussed the diminishing rates of vaginal hysterectomy and that it's absolutely the preferred and evidence-based way of doing hysterectomies. It's associated with better patient outcomes, shorter recovery, fewer complications, lower risk of urinary tract injury, bowel injury, thromboembolism, total mortality, etc. It's definitely the least invasive approach. There's no incisions at all on the abdomen. It's cheaper. It's up to $5,000 cheaper per case than robotic hysterectomy. And that's not even including the fixed costs of robotic hysterectomy, like maintenance and the cost of the machine itself. In fact, in most hospitals, vaginal hysterectomy is the only method of hysterectomy that turns a profit. And it's recommended by the American College of Obstetricians and Gynecologists, the AAGL, and other professional societies as the preferred route of hysterectomy whenever possible. And it's possible in the majority of cases, as this new study confirms. In fact, the recommendation is one of the things that Dr. Advincula really takes issue with, that our professional societies continue to make this evidence-based recommendation. He writes that the advent of robotics, the morcellation controversy, paradigm shifts in residency training, and a push towards value-based medicine are things that are influencing our current thoughts about hysterectomy approaches. And they definitely are. The advent of robotics has been a negative influence, not a positive one. It's led to vast overutilization, and people wanting to learn how to do them inevitably takes away cases that could have been done in a less invasive way vaginally in particular, or even just with straight stick laparoscopy, and turns them into robotic cases for no good reason. The Da Vinci folks told me a decade ago that I should take my next 30 easiest hysterectomies and do them on the robot to get through the learning curve. That's obscene. In fact, Dr. Julian in that 2008 editorial talked about some of the reasons why there's been a decline in the rate of vaginal hysterectomy. And one of the things he talked about was clever marketing and the idea that newer equals better. And of course, the issue with less training. Those are not new or recent problems. The robot exemplifies clever marketing and an idea that newer equals better. There are shifts in residency training, and hopefully those can shift in a positive way. People who aren't interested in doing gynecologic surgery need to leave cases for those who are, and the tracks and residency can help with that. But more importantly, the attendings in academic programs need to emphasize the correct and most appropriate way of doing hysterectomies, which is vaginal, instead of focusing on the robotic route. We have a limited number of cases to offer. Let's spend that experience in the right place. Advincula mentioned the push towards value-based medicine. Well, that absolutely supports the vaginal route, which is $5,000 cheaper on a case-by-case basis. And the true costs are likely higher when you account for total societal costs like decreased economic productivity of the patients, robot maintenance, purchasing robots, and things like that for the hospitals. The majority of hospitals in America don't have a robot, can't afford one, and don't need one. Advincula is clearly upset that the American College of OBGYNs continues to endorse vaginal hysterectomy as the preferred route. He says, and although clinical evidence and societal endorsements support vaginal hysterectomy as a superior high-value modality, end quote, so he agrees that that's true, but he says that despite this, the rate of vaginal hysterectomy continues to decline. Yes, because of corporate influence and the push to sell endoscopic equipment. That's where the money is there. That's where the money is to be made, selling consumables and new instrumentation. We don't really need any consumables or new instrumentation to speak of to do vaginal surgery, but when you introduce laparoscopic or robotic programs to a hospital, there's a ton of money to be made if that's what you sell. He does comment on the study, but I really think in a very unfair way, and I'm really kind of surprised that this was published. He says that the study did demonstrate the safety and feasibility of vaginal hysterectomies for the majority of patients at the Mayo Clinic, and the "at the Mayo Clinic" dig is on purpose. Yes, they found that the majority of patients in their population can undergo a vaginal approach, but he criticizes it because he says it's not generalizable. He says the algorithm in particular is not generalizable because the patient population studied was mostly white and had overall lower uterine weights. Well, I'll tell you, most women in the United States who undergo hysterectomy are white and have uteruses under 200 grams. So yes, it's absolutely generalizable and absolutely shows that the majority of women, at least 50%, and I would say up to 85% of women having hysterectomies in the U.S. could be and should be accomplished vaginally. The scientific evidence is overwhelming. Here's yet another study, this one from last year, showing that the perceived contraindications to vaginal hysterectomy are totally bunk. Advincula says that the expertise of the surgeons contributed to the good outcomes, and undoubtedly they did, although I'll say I take issue with the techniques they used and would argue that the simplified vaginal hysterectomy techniques I described in my book would have produced even more favorable results in the hands of less skilled surgeons. This is not 1936. There are better, simpler techniques. We've come a long way in how we accomplish vaginal surgery, and it's a generalizable technique that can be taught if it's done correctly. What I take most issue with is Advincula's criticism of the study not being done in a diverse population. He says, quote, implementation of this algorithm in a large and diverse metropolitan area such as New York City or Chicago, even if performed by highly skilled surgeons, would likely yield different results. And that's really unfair, and I'm really surprised that this claim was allowed to be published without any supporting evidence. If he's concerned about the fact that African American women have more fibroid uteruses or larger uteruses on average, well, they've stratified those results, so there's no need to break it down by race for that reason. Does he mean to suggest that it's harder to do a hysterectomy on women of color than it is on white women? That's an absurdity. That has no evidence basis, and of course no footnotes provided. It's just a shallow criticism. It sounds like something from a sophomoric literature criticism course where you look at the demographics and see if it applies to your patient population. As I said already, it does apply to the majority of patients in the United States and Canada. So there's that, and that's the point of the paper. But even if not, you need to really be specific when you invoke those sorts of claims. What evidence do you have that it's harder to do a hysterectomy on a black woman than it is on a white woman who has the same size uterus? Because that would be the only legitimate reason to make that statement. He says that because of this, though, and we're just supposed to take him at his word, he says there's real-world practical practice challenges to vaginal hysterectomy. And as the authors of the study discussed, the minimum of only 15 hysterectomies over 4 years of residency training, vaginal hysterectomies, is probably not adequate to sufficiently train folks. And he asks, should vaginal hysterectomy as a route of hysterectomy be promoted in the setting of least taught and least performed among a majority of practicing low-volume surgeons? Well, it's only least taught and least performed because people like him are choosing not to teach it and not to perform it and not to teach it to his residents. So that's a fixable problem. Robotic hysterectomy just a few short years ago was the least taught and least performed, And for many people, there's still a steep learning curve. The majority of gynecologists still have never done one, and robots aren't everywhere. I would say that the majority of women don't live within an hour of a hospital that has a robot in it. And even when they do, they're often faced with low-volume robotic gynecologists who do very few of them and are just frankly not good at them. They take 3 or 4 hours and they have 5 ports on their belly. So the same problems exist for both routes. It's just a question of what are we going to emphasize? Where are we going to refocus our resources? On the safer and cheaper and better outcome way of doing it, or the more expensive industry-funded route? He says, interestingly, that he takes issue with the authors because he says robotic surgery, despite being a minimal access route, was labeled a more invasive route. Well, it is a more invasive route. There's no doubt about that. When I do a vaginal hysterectomy, there are 0 incisions on the belly. So even if you're a 1-port roboticist, there's still 1 incision on the belly, and a pretty big one. And if we're being honest, most women have between 4 and 6 ports in the United States. Vaginal hysterectomy is absolutely a less invasive route, and saying so is not a bad thing, but of course the most minimally invasive route of hysterectomy just isn't being taught at so-called minimally invasive fellowships. Advincula says that although historical evidence demonstrates that vaginal hysterectomy is associated with better outcomes when compared to other approaches, a multitude of studies now exist that challenge this notion. Okay, well, let me rephrase that. Another way of saying that is, although most every published paper ever published, or in his words, historic, says that vaginal hysterectomy is associated with better outcomes, he cites 2 studies to support this absurd claim. One is from industry-gathered data in a publication sponsored by and written by employees of Da Vinci, and the other one is from a speaker for Da Vinci that used single institutional data comparing excellent roboticists with poor vaginal hysterectomists. Neither are studies that actual experts on hysterectomy give any credence to. That kind of cherry-picking and selective biased approach to the literature is not evidence-based medicine. Frankly, it's abhorrent. It's exploitative. This is why we do systematic reviews, to avoid such cherry-picking of poor data. The bulk of the literature, the consensus of the scientific opinion, and therefore the consensus of the American College, is that vaginal hysterectomy is the safest and least expensive route associated with the best outcomes. He says, quote, from a policy perspective, vaginal hysterectomy exemplifies the difficulty of balancing a historically desired surgical route with the reality of clinical practice today. There he used that word historical again, maybe appealing to the novice bias that new is better. It's not a historically desired surgical route. It's the route that most women still want. They want to be able to go home 3 hours after their surgery and have no incisions on their belly and return to work in a week. Our hospitals want to spend less money and be able to have a sustainable surgical program. The women want to return to work more quickly and provide for their families. They want a lower risk of bladder, ureter, and bowel injury. They want less pain. It's not historically desired. It's what's desired now. It's just a question of whether or not people want to do what is ethically right and the evidence-based right thing to do. He concludes, as surgeons critically appraise the various routes of hysterectomies, one should not split hairs and subtly pit one minimally invasive route against another. Well, we're not splitting hairs here, and I'm not being subtle. Take the cost issue. Let's assume that vaginal hysterectomy and robotic hysterectomy were identical in terms of their outcomes. The cost issue alone, as the authors of this new study also pointed out, is more than enough reason to select vaginal hysterectomy. But there's more. It's not just cost. It's all the other issues I've already mentioned. So we're not splitting hairs, nor are we being subtle when we say that one procedure is better than the other. The same difficulties that he has highlighted that exist for vaginal hysterectomy exist for robotic hysterectomy. For example, there are a large plurality of people who are really good at neither surgery. Women often have to travel to find someone who's good at doing the surgical route that they need, things like that. But that doesn't stop us from doing what's necessary and what's right. I think we both would agree that low-volume surgeons should not be doing these cases, and whether that's a low-volume roboticist or a low-volume vaginal surgeon, they shouldn't be doing them. We have to solve that problem as a professional society. We have to start saying that the 80% of gynecologists who do fewer than 10 hysterectomies a year probably should just refer to a higher volume center. But now we need to construct those high volume centers of excellence. And it's just as easy, perhaps easier, to construct them to be vaginal centers of excellence than to make them robotic centers of excellence. My colleague, Dr. Antonia Roberts, sent me this rewrite of those sentences. From a policy perspective, robotic hysterectomy exemplifies the difficulty of balancing a currently profitable surgical route with the reality of clinical practice today. And one should not split hairs and regard one approach of unnecessary abdominal access to be better than another. but instead should work toward the goals of minimizing surgical risks and morbidity, which still occur at higher rates in endoscopic and open approaches compared to vaginal approaches. Yeah, exactly. Rhetoric. Does that mean we don't ever need the robot? We need it some, especially in the oncology world, although frankly, most of what can be done with a robot can be done with straight stick laparoscopy and done less expensively. So that's a whole other issue to discuss, but the bottom line is this new article is wonderful. The editorial really should not have been published, and I would invite each of you to write a letter to the editor expressing your dismay that essentially an industry-funded hit piece was allowed to detract from an otherwise excellent scientific article, an article which should have been published 3 years ago. We're supposed to practice ethical and evidence-based, science-based medicine, and that supports the route of vaginal hysterectomy, and no amount of clever marketing can change that. We have to do some work to improve our specialty. That work will likely not be funded by industry.